Hello, welcome everyone to this very special event, part of the USC Institute on Inequalities and Global Health virtual lecture series. My name is Sophia Greskin, and as director of the Institute, it's my great privilege to welcome you to this conversation with Jonathan Cohen, Acting on Equity, US Foreign Policy, and the Future of Global Health. As some of you may know, Jonathan recently joined USC as clinical professor and director of policy engagement for the Institute, and we're obviously thrilled to have him with us. The event is part of a larger initiative that Jonathan is spearheading for the Institute to translate our research and teaching in global health into an agenda for US federal policy action. So clearly all of us at the Institute are really seized by the opportunities that now seem to exist in Washington to advance health equity. And I say that within the context of COVID, with what's happening in Ukraine, with the conflicts in other parts of the world, and the deep polarizations that are within our country. So we're not naive about the risks, but we're also acutely aware that our home is in California, which has historically been a seat of US leadership in global health. And we think that gives us a perspective and as well as a responsibility to do what we can to help shape US federal policy on global health. At our last federal policy event, we brought in two members of Congress from California, Representative Katie Porter and Representative Judy Chu, to ask the question, why should Californians care about global health? It was really remarkable to hear two representatives from really our own neighborhood speak with such vision and passion about advancing global health in such, can I say, equitable terms, and the framing as a matter of shared prosperity between people of all countries, have to say really resonated with all of us. So at the Institute, in doing this, we're very much in the learning mode, and we're very, very grateful to the many experts in DC and around the world who are going on this journey with us, many of them who have already shared their insights and many with whom we are just starting to engage. So we really see today's talk as a launching pad towards what we hope will be a more significant effort to conceptualize and to foster dialogue around the opportunity to meaningfully embed health equity in US foreign policy. In the short term, we're going to follow up on this lecture with a variety of efforts to meaningfully bring students into this work. And we're planning a super exciting event with health equity leaders from DC and around the world that we're going to be announcing in the next couple of weeks. So stay tuned. And just a few more words just to say something about our speakers. So Jonathan Cohen has since this past November been clinical professor and director of policy engagement with us here at IIGH. Before joining us, though, he was director of the Open Society Public Health Program, where his grant making and advocacy was all about improving social inclusion in public health policy and practice. So there's a clear link to what he's talking about today. He directed the foundation's $39 million public health portfolio and chaired its leadership committee advancing diversity, equity, and inclusion. And in his 16 years at Open Society, he directed funding and advocacy efforts to promote health and human rights in over 40 countries in ways that I think are really critical to the discussion that we're having here today. The plan is that Jonathan is going to talk to us for about 40 minutes or so, and we plan to leave plenty of time at the end for Q&A and actually discussion. So please do use the Q&A function. And with that, I'm delighted to say, Jonathan, the floor, or shall I say the Zoom, is yours, please.
Thank you. Thank you, Sophia. Thank you, Professor Howard Hu, our department chair of Population and Public Health Sciences. Thank you all for coming. It really is such a privilege for me to be giving my first lecture as a new member of the USC faculty in the Institute on Inequalities and Global Health, particularly at this moment and in the company of all of you. I am very aware that I am offering these reflections at a moment when the concurrence of multiple large-scale global processes, from COVID-19 to climate change to the Black Lives Matter movement, have unleashed a generational opportunity to place equity at the center of US foreign policy. As I will describe, I believe the Biden-Harris administration has seized this opportunity in some respects while retreating in others. I think this is not a moment to take lightly or cynically. It's a moment to clearly analyze the potential for a sweeping change in how we understand America's role in the world and of the forces arrayed in favor of that change and against it. I think it's important first to understand what led us to this moment of opportunity. The past 2 decades have witnessed the ascent of global health as an American foreign policy priority, exemplified by the US President's emergency plan for AIDS relief, the global health security agenda, US leadership in fighting tuberculosis and malaria, and many other examples. And alongside these programs has emerged the practice of global health diplomacy, GHD, which comprises the positioning of global health within our foreign policy negotiations, as well as the emergence of new forms of global health governance. So if our goal has been to advance health as an American foreign policy priority, we can say mission accomplished. But health equity, that's another matter entirely. And early actions of the administration do imply a recognition of that. On his first day of office, President Biden issued a pair of executive orders, one of them calling for a whole of government approach to advancing racial equity, and a second calling for a unified government approach to COVID-19. The same day, our president wrote to the Secretary General of the United Nations and retracted the decision of the previous administration to withdraw from the World Health Organization. And the president went on to appoint a number of health equity leaders to key positions in his administration. Dr. Marcela Nunez-Smith to chair the COVID-19 Health Equity Task Force, Lois Pace to head the Office of Global Affairs at the Department of Health and Human Services, John Kengasong, the first person of African origin to lead the US government's program to combat HIV worldwide. So it is very possible that the Biden-Harris administration is attempting not only to break from the immediate past, but potentially also to usher in a new era of global health diplomacy rooted in equity. With that in mind, I want to guide us through 3 questions today. The first question, how would a new emphasis on equity reshape and augment our understanding of global health, including in relation to human rights? Second question, what would it look like in practice to position global health equity more prominently within American foreign policy and diplomacy? And third question, what obstacles would exist to this new positioning now? And what are some of the key opportunities in front of us? So let's begin by conceptualizing equity within global health. In any field, the concept of equity offers a practical expression of the moral idea of justice, as well as a way of measuring fairness of outcomes. The World Health Organization defines equity as the absence of avoidable or remediable differences among populations or groups defined socially, economically, demographically, or geographically. This definition is expansive enough to include groups of people or groups of countries. In his executive order, President Biden defined equity as the consistent and systematic, fair, just, and impartial treatment of all individuals, including individuals who belong to underserved communities that have been denied such treatment, such as Black, Latino, and Indigenous and Native American persons, Asian Americans and Pacific Islanders and other persons of color, members of religious minorities, lesbian, gay, bisexual, transgender, and queer persons, persons with disabilities, persons who live in rural areas, and persons otherwise adversely affected by persistent poverty or inequality. And he went on to define underserved communities as populations sharing a particular characteristic, as well as geographic communities that have been systematically denied a full opportunity to participate in aspects of economic, social, and civic life. Now, what has become clear in the last couple of years is that it is impossible to achieve this broad definition of equity in global health without interrogating the very meaning of global health itself. The reason for that is that our field of global health remains tethered to a set of institutions and assumptions and practices that reflect its colonial origins in the field of tropical medicine, which is a field historically concerned with preventing the so-called tropical diseases of developing countries from spreading to the rest of the world. This reality has led to calls to reinvent the field of global health on more equitable and indeed more global terms, or in other words, to decolonize the field. Now, for a wealthy country like the United States, that means a shift away from conceptualizing global health as being about the health of people over there, as though we are not all living on the same planet. Instead, it means acknowledging the interconnectedness of health of people in different countries and the myriad ways in which our health outcomes are commonly shaped and determined by decisions that transcend national borders. This is, of course, exemplified by the now familiar COVID-era mantra that no one is safe until we are all safe. Equity in global health also holds a close relationship to human rights, which of course hold a more explicit place in American foreign policy, if not in deed, then certainly in word. The late Dr. Paul Farmer brought together the two concepts of equity and rights. He famously stated that the essence of global health equity is the idea that something so precious as health might be viewed as a right. But if that is true, it would likely require a transformation in human rights practice, as he himself argued. In one of Dr. Farmer's last essays, he and his co-author, Alicia Ellie Yamin, traced health inequities not only to observable human rights violations, but also to what they called insidious structural means. And they joined the call to liberate the field of global health from its colonial origins and mindsets. I would add an additional dimension to the relationship between human rights and equity, and that is their shared struggle against authoritarianism. As our institute here at USC and many others have shown, during the COVID-19 pandemic, authoritarian regimes abused their public health powers to impose draconian countermeasures and states of emergency that not only infringed basic rights, but that disproportionately affected those least able to withstand them. These included, of course, overbroad surveillance powers, punishments for violating shelter-at-home orders, censorship of health information, and other measures that served no legitimate public health purpose. I think that at a core level, many of these indiscriminate measures favored a vision of human obedience over a vision of human diversity. They imposed a single standard of behavior on a diverse society, rather than recognizing that even in a single pandemic, different people have different needs. So in that way, I would argue that equity, in addition to rights, provides a democratic safeguard against authoritarianism. It calls for measures that provide diverse communities with, and I'll quote the executive order here, a full opportunity to participate in aspects of economic, social, and civic life. So to sum up this first section, I think that to achieve real global health equity, we need to do at least two things. First, we need to dismantle the embedded hierarchies and power differentials that structure the way we think and act, that colonize our minds. And second, we need to work to enable human diversity over the imposition of uniform standards of thought and behavior. And I'm sure it's apparent to many of you listening that these two things are also the two things we need to do in our schools, in our universities, in our workplaces, and in our government offices. Indeed, like the call for human rights, the call for equity begins at home. Begins with how we retain and nurture talent and how we unleash the potential of diverse students and colleagues. I think in that sense, the kind of artificial distinction between internal institutional work on diversity, equity, and inclusion, which, by the way, is also a major policy priority of the Biden-Harris administration, and the kind of outward-facing, mission-oriented work on promoting health equity, is ultimately a false distinction, because I think both of those things are essentially aiming for the same kind of transformation. So with that broad framing of equity and global health in mind, let's ask the second question, which is, what might it look like in practice for global health equity to occupy a central position of American foreign policy? And I think that would look very different from simply adopting health as a policy priority. It would actually require a fundamental reshaping of the very concept of global health diplomacy, or GHD. And the reason for that is that many of the historical justifications for embedding health within American foreign policy actually stand in tension with equity-based thinking and analysis. A little over a decade ago, toward the end of what many have since called the decade of global health, the scholars Labonte and Gagnon described 6 broad arguments for why governments were positioning global health so prominently in their foreign health policy. So these were things like security, development, global public goods, trade, human rights, and ethical and moral reasons. And the authors evaluated how each of these justifications contributed to global health equity. And what they found is that while each of these frames has something to offer, all have their limitations from an equity perspective. So for example, if you justify global health and foreign policy through the so-called high politics of national security, according to these scholars, this could triage foreign assistance further away from where it's needed, because it disproportionately directs funding and attention to ills that are politically deemed to be national security risk, such as pandemics. And we saw that phenomenon with COVID-19. But even the so-called low politics of development and rights and ethics pose equity concerns, according to these authors. Because, for example, it could prioritize assistance to countries with the highest disease burden, but fail to address internal inequities within middle-income countries. Or it could emphasize litigating legally enforceable claims for the individual right to health over collective action. But the main conundrum that these 2 authors pointed out was that the most compelling political rationales for GHD, global health diplomacy, namely security, trade, and aid, were also the most problematic ones from an equity standpoint. So given the palpable traction that health equity has gotten and the stated commitment of our administration to it, and given also the profound limitations of the current global health diplomacy paradigm from an equity perspective, I'm going to argue today that it's time for the US government to articulate a distinct global health equity diplomacy, a GHED, to help guide American foreign policy in the post-pandemic period. And I think that diplomacy would require at least 4 things. The first thing it would require is applying health equity impact assessment to all aspects of American foreign policy, especially those that shape and govern health from outside the health sector. The second thing it would require is positioning equity between nations as a foreign policy priority, given the profound role of economic inequality as a driver of inequity. The third thing it would require is prioritizing equity within nations as a strategic and programmatic priority in all global health programs, particularly through priority attention to the social and political and commercial determinants of health. And finally, it would require committing to procedural equity in the design, implementation, and evaluation of health and development policies and programs. So let me just give a quick example of what each of those four things could look like in practice and how they could improve health outcomes. So the first dimension, I argue, of a new global health equity diplomacy, and I'm going to call it GHED, is applying health equity impact assessment to foreign policy. Health equity impact assessment is a more evolved practice in certain places than others. But I think a good concrete example of where it could be seen in this country is in our climate and environment diplomacy. So in a context where we know that the health effects of climate change are inequitably distributed between and within countries, a US foreign policy rooted in GHED would require the Office of the Special Presidential Envoy for Climate to screen whether its activities, from its engagement in the Paris Agreement to its investments in clean energy, had the potential to impact health disparities, either positively or negatively, between groups or between countries. And depending on the results of this screening, the State Department would then scope which groups or countries might be affected. They would drill down on the impacts, and they would develop strategies for mitigating negative effects, building on positive effects, and they'd monitor and evaluate the impact of those strategies and their impact on equity. That process would be perfectly in line with a 2008 recommendation by the World Health Organization's Commission on the Social Determinants of Health, which was to apply health equity impact assessment to all economic agreements, market regulation, and public policy. The second dimension of a new GHED I called for is positioning equity between nations as a policy priority. I think the best example I can give of this lies in the field, of course, of COVID-19 vaccine equity. So with the COVID pandemic continuing to outpace the distribution of vaccines globally, it's absolutely critical that all countries meet WHO's target of vaccinating 40% of their population by the end of this year and 70% by the middle of next year. Yet dozens of countries are not on track to meet this target. Why? Because as entire countries, they are excluded from the global vaccine market. So what equity between nations means in a context like this is a more equal distribution of the capacity to manufacture vaccines and to purchase vaccines. Yet the reality is that manufacturing capacity is cornered by a handful of companies in rich countries, and purchasing power is limited by national treasuries and in turn by debt servicing and other aspects of global economic policy. So a US foreign policy that centered health equity would make it a priority, not only to donate our surplus vaccine doses to other countries, but also to reduce those root inequities in manufacturing capacity and purchasing power that ultimately prolong the pandemic for everyone. So the third dimension of the new GHED I mentioned earlier is prioritizing equity within nations as a program priority. And the example I want to give here, and there's so many I could give, really lies in the field of social protection. Because I think as all of us learned during the pandemic, basic social protections like paid sick leave and unemployment insurance and workplace safety regulations and eviction moratoria really proved to be the difference between being able to survive the pandemic or not. People who are forced to choose between their lives and their livelihood very often end up engaging in hazardous work that puts them at greater risk of infection. And people who are forced into crowded congregate homeless shelters face similar risks. And in the United States and other countries, these vulnerabilities are disproportionately faced by Black and Brown communities who also have lower per capita rates of health insurance coverage and higher rates of some chronic diseases that are also risk factors for COVID-19. So a foreign policy informed by health equity would do a couple of things. First, it would promote necessary cross-learning between the United States and other countries with similar legacies of institutionalized racism about the best ways to guarantee access to those social determinants of health. And moreover, It would prioritize investments in programs abroad that guarantee access to those determinants, like employment, housing, and education, as an imperative of public health and pandemic control. The fourth and final requirement of a new GHED that I mentioned is procedural equity in program design. And I want to give an example of this from the field of HIV and AIDS. Broadly defined, procedural equity basically refers to a commitment to communities having a voice in decision-making processes. So in the context of US global AIDS assistance, procedural equity has included active steps to mobilize communities in other countries as active participants in HIV programs, not just as passive beneficiaries. So that could include community consultations in designing programs under the President's Emergency Plan for AIDS Relief. It could also include the participatory governance model of the Global Fund, to which the US is a major donor. And these efforts are really important to health because communities ultimately are in the best position to identify their own needs, especially in a stigmatized epidemic, and because programs that are designed by communities are more likely to earn the trust and uptake of their intended beneficiaries. So what's evolved is a practice of directly funding community groups, establishing consultative mechanisms, and setting up feedback loops. And a US foreign policy that is rooted in health equity would mainstream that practice throughout all of our global health programs. So if these provide the kind of contours or requirements of a new GHED, what would be the political justification for taking this new approach? Or to put it a little differently, if the historical justifications for the traditional global health diplomacy approach, namely security, development, global public goods, trade, rights, ethics, have been observed to stand in tension with equity, what possible justification could be left for a diplomacy rooted in equity itself? Now, I wish I had the answer to this question. Perhaps during the comment period, people want to suggest what they think it is. I think it's important to pose it. And I suspect, given the lessons of COVID-19, that one possible justification might simply lie in enlightened self-interest. And I believe this in part because the notion that no one is safe until we're all safe, which has become something of a slogan, I think, for global health equity, is neither purely self-interested nor purely altruistic. Rather, it seems to me to combine both of these things into a cardinal insight about human existence. And that is that pockets of inequity that affect the underserved have the potential to engulf and sicken the entire planet. And that our species only survives and prospers by sharing with each other. Now, whether we reflect this core insight in our politics is obviously a different matter, and it's a political choice. So that's why I want to turn to what the obstacles I think are to making that choice, and then end on some of the opportunities to overcome them. So let's examine together some of the main obstacles that might exist to embedding health equity within US foreign policy. A first obstacle I see is policy incoherence. So because the concept of equity is so multifaceted, and because responsibility for global health is so diffused across so many parts of the US government, it's very possible for the US to advance health equity in some areas while stalling it in others, which results in a kind of one step forward, two steps back dynamic. And I think the experience of vaccine equity is illustrative again here. So the recently launched USAID Initiative for Global Vaccine Access actually includes substantial equity components. It includes support for health information systems to better evaluate vaccine distribution equity, and it supports in-country vaccine manufacturing, along with the International Development Finance Corporation's manufacturing investments. But at the same time, you have another branch of the US government that might agree to a compromise at the World Trade Organization on another critical aspect of manufacturing equity, namely the waiver of intellectual property rights that protect pharmaceutical monopolies over the know-how to manufacture vaccines. So literally, one branch of the government potentially undermining the other. Just this week, the European Union floated a compromise on the TRIPS waiver that would withhold key aspects of this know-how and would exclude diagnostics and therapeutics from any waiver. And this would undermine the US's own equity-informed effort in other areas of vaccine access. So those kinds of contradictory positions do not, in my view, bode well for a coherent foreign policy rooted in health equity. This is obviously closely related to a second obstacle, which is vested interests, right? So no matter how complex the issue of vaccinating the world, and of course it's not simple, the simple truth is that pharmaceutical companies profit massively from monopolies and scarcity, and the government has bargained away its own intellectual property rights in return for these companies' investment in bringing pharmaceuticals to market. That's just a fact. And while it is well within the government's legal power to reclaim those rights and to force competition, and even to nationalize production if they wanted to, the reality is that the pharmaceutical industry is one of the most powerful lobbies in Washington, and even most Democrats approach their relationship with pharma in terms of what they and pharma can do for each other rather than what pharma can do for the public. And this is further fueled by a deep and abiding myth that pharma invented the COVID vaccine when in fact the basic science was funded by your and my taxpayer dollars. So these vested interests and these false narratives also stand deeply in the way of a foreign policy rooted in health equity. I think a third obstacle that we have to acknowledge is pandemic fatigue. We're over 2 years into COVID-19, and the sense of urgency that fueled political support for this bold equity agenda is now giving way to a dangerous political calculation to emphasize a return to normal. And this is obviously a threat to equity. Why? Because the benefits and burdens of lifting pandemic countermeasures, whether it's mask mandates or ventilation upgrades or what have you, will inevitably fall on the most vulnerable and underrepresented, especially the immunocompromised. And we've seen in the last couple of weeks how much anger this has fueled, that the administration is succumbing to a narrative of normalcy rather than taking basic precautions that would help to prevent and mitigate future surges. And that is probably what contributed to the administration's failure to defend a recent congressional budget request for even a fraction of the $17 billion it estimated it needed for domestic and global COVID responses. I'm going to get to the opportunities in a second, but I'm going to give you a couple more obstacles to the new GHED. The fourth obstacle I want to discuss is the potential for retrenchment in foreign aid. Now, even though research shows that most Americans agree that vaccinating the world would keep them safer from COVID-19, and even though we have had a spectacular bipartisan consensus on global AIDS programs for over 2 decades, the reality is that most analysts will agree that investing in global health and development is not a winnable electoral issue in the United States, and that in any case, global health is the project of a peaceful and a prosperous nation. And so the economic crisis occasioned by COVID, combined with Russia's invasion of Ukraine and its nuclear brinksmanship, have the potential to shatter the sense of peace and prosperity that is thought by many to be key to sustaining public support for global health. And for sure, the recent congressional budget decision may be evidence of this. And this may be linked to a related obstacle, which is that the bipartisan consensus on AIDS has not translated into a similar consensus on COVID-19, on pandemic preparedness, or on global health equity more broadly. The last obstacle I want to touch on is fragmentation in campaigning. So unlike a popular movement for a single disease such as HIV, a movement for global health equity is necessarily more diffuse, more expansive, and therefore more fragmented. And this can make it very difficult to coalesce around a unifying theory of change that's capable of identifying when you're making progress and when you're not. So incremental changes, which are really the stock and trade of Washington, may or may not advance towards the larger goal. And individual campaigners and organizations may do incredible work advancing what they rightly see to be dimensions of global health equity without the underlying logic of US foreign policy ever really changing. And then you have efforts to protect fragile gains like PEPFAR or the US contribution to the Global Fund, which may consume necessary effort and then become stand-ins or proxies for the larger project of advancing equity. Now, these are understandable obstacles that are not unique to this field, and they are daunting. But I think each one does point to and reflect an opportunity, right? The opportunity to promote policy coherence, to tell a new story about pharmaceutical innovation, to put in place the measures to prevent the next pandemic, to recommit to international development, and to unite our campaign efforts. And I want to conclude by discussing some immediate platforms, like over the next 6 months to a year, to advance a global health equity diplomacy, a GHED in foreign policy. So overarching all of the opportunities I'm going to talk about is, again, the president's executive order on advancing racial equity, because that order requires every agency of the federal government, domestic and foreign, to develop an equity action plan. So with global health spread out over so many agencies of the federal government, the State Department, USAID, the National Security Council, HHS, this really is an enormous equity opportunity. And in all of those areas, I would say equity can be embedded at least 3 levels: at the level of strategy and programming, at the level of finance and investment, and at the level of governance and diplomacy. And I'll reflect briefly on each level and then we'll conclude. So first is the level of strategy and programming. And here is the good news. I mean, the opportunity to embed equity into the administration's global health strategy and programs is already being felt. So newly minted strategies and guidance documents from programs like the President's Malaria Initiative, PMI, and PEPFAR have already elevated equity as a core principle. So for example, the just issued guidance to all PEPFAR supported countries places a particular priority on addressing persistent inequalities experienced by children, key populations, and adolescent girls and young women, and emphasizes that an equitable approach tailors services and advances policies to achieve optimal outcomes for all. This is a big win. The guidance acknowledges that investment to date has not been of sufficient scale and impact to achieve intended outcomes for these populations. And it also says that in a context of limited public resources, those limited funds must support the most vulnerable and disadvantaged. This is the first time that PEPFAR has accorded this level of priority attention to equity. And it, of course, draws on a wealth of knowledge in the domestic United States about placing equity and the social determinants of health at the core of the HIV response. At the level of financing and investment, which is the second level of opportunity, I think the landscape is more unpredictable, but it is not without significant promise. And 2 areas we need to watch here are pandemic financing and the upcoming replenishment of the Global Fund to fight AIDS, tuberculosis, and malaria, both of which the US has been very vocal about. And I think these 2 processes are timely opportunities to test a new paradigm of what's being called global public investment, or GPI. And GPI is a concept of development finance that is co-created by stakeholders in the global North and the global South in which all countries contribute, all countries benefit, and all countries decide. So this is very much an equity-informed concept. And its purpose is not to create a dedicated new fund with all that infrastructure and overhead, but rather to fill gaps in existing global health infrastructure. So if you apply GPI principles to something like pandemic financing, the way it would work is that each country would essentially create a new budget line for GPI, and they could resource that line in different ways, and their contribution would go towards different outcomes of what was collectively determined by all as the overall goal for pandemic preparedness and response for a given year. And experts have even developed specific proposals for how GPI principles can be applied to the US government and the Norwegian government's proposal for a $10 billion a year global health security financial intermediary fund, so-called FIF, hosted by the World Bank and independently governed. So this proposal for a FIF is currently lacking buy-in from non-traditional donors, but that creates an opening for equitable GPI principles of legitimacy and fairness and inclusion to rescue the concept of a FIF and to advance global health equity diplomacy at the same time. And if I sound overly optimistic, that's just my nature. Finally, the third level of opportunity is the level of governance and diplomacy. And here the opportunities we must watch are, of course, the revision of the international health regulations by the World Health Assembly and the negotiations for a new pandemic treaty or accord. These are two processes that both emerged from the recognition that our existing global health governance architecture failed to prevent COVID from metastasizing into a global pandemic, and that stronger safeguards are needed to prevent everything from misinformation, to the failure to openly share data, to the hoarding of essential supplies and commodities. Now, while it's too early to predict which, if either of these two processes holds scope for advancing health equity, I think it's clear that both have the potential to do so, and we have to act as though both have the potential to do so. So in early March, for example, just this month, member states of the WHO Africa region called for the inclusion of 6 equity provisions in the revision of the IHR, including equity and obligations of prevention, detection, and control, provision of financial assistance and technology transfer to developing countries, and obligations to facilitate production, availability, and access to medical countermeasures. And just days later, the South Center published a set of specific equity-informed recommendations for a pandemic treaty or accord, drawing on the recommendations of the Independent Panel on Pandemic Preparedness and Response. So I think we're seeing a steady groundswell of support from the Global South for a new instrument and a new IHR that equitably distributes the obligations and benefits of a pandemic response. And I also think that the US and other wealthy nations are under pressure to get on board and to prevent another so-called catastrophic moral failure, to quote the Director General of the WHO's description of the current state of COVID-19 vaccine inequity. So let's conclude. I really want to thank you. I want to thank you for the opportunity to consider what it would look like to truly embed health equity into US foreign policy and to usher in a new era of global health equity diplomacy. I've tried to argue that while health itself has ascended in the US foreign policy space, health equity has not yet enjoyed such an ascent, and that this would require a new way of conceptualizing global health that reroutes power and focuses on enabling the flourishing of human diversity. And in practice, that would mean applying health equity impact assessments to all aspects of American foreign policy, positioning equity within nations, rather between nations, as a foreign policy priority, prioritizing equity within nations as a strategic and program priority, and committing to procedural equity in program design. And that all of this would require a new and different overall justification than those that currently undergird global health diplomacy. The obstacles to this are, of course, many and include policy coherence, vested interest, pandemic fatigue, retrenchment in foreign aid, and campaign fragmentation. But the opportunities abound at the level of strategy and programming, financing and investment, and governance and diplomacy. Sophia, before I turn it back to you, I just want to reflect that I really believe that to fully grasp and act on this moment of historical opportunity, we need the full interdisciplinary might of our university and other universities. We need to bring together the tools of global health with the expertise of political science and foreign policy and transformation studies in order to truly understand when large-scale paradigm shifts in foreign policy can occur. I think the answer to whether it will occur lies only in a clear understanding of when and how our government and our public policy act as a force for large-scale social and political change, and when they don't. And I also suspect that if and when this change occurs, it will not occur quickly. As Partners in Health and the Global Health Justice Partnership put it last year, COVID is the sprint, equity is the marathon. And I guess in a marathon that ends in justice, there are no shortcuts. So let me end there. Thank you very, very much, and look forward to whatever time we have for discussion.
Thank you, Jonathan. That was truly brilliant. And it absolutely got my wheels turning. And I'm sure others as well. Folks, please add your questions. I'm going to take the prerogative of basically being able to ask you a question, because it's something that I've been struggling with that really came up for me as I was listening. And first of all, I want to say, I love the new acronym, GHEAD. I think we should say GHEAD, right? So, I thought, but my question comes back to something that I struggle with, which is who determines what's equitable, right? Is it the institution in power? Is it communities most affected? When you were talking about the health equity impact assessments being done by the government. Then when you were talking about procedural equity, it was about being done by community. And I was struggling myself with trying to think about how to think about who decides and kind of what's the kind of common way of thinking about it. I'm not sure you have to have like a direct answer, but I'm really grateful for any thoughts you might have.
Yeah, no, thank you. I think where I would land there, Sophia, is equitable process for determining what's equitable. I think procedural equity has to be the guide there. And in the few places where we have seen IIGH, health equity impact assessment, evolve, it has been participatory, right? It hasn't been bureaucrats deciding, it's been community informed. And I think we need to really learn from the experiences. So that's where I would initially go on that.
Thank you. No, it's super helpful. So notes come in and basically thanking you for the rich and thought-provoking talk and appreciating the optimism. But one challenge that you touched on briefly is the redistribution of power that's needed to increase equity and health diplomacy globally. So how do you think this can be done without currently quote unquote powerful countries such as the US feeling threatened or weakened?
Look, my answer is in how I would frame the question. Can we convince our elected representatives that it is not in our interests to monopolize so much power? That's the question I want to put out there. And is the kind of leadership that we want a leadership that is threatened by that?
So that's interesting. So there's a follow-up question that someone else has put in there that kind of connects to that point, I think, which is what sort of mechanisms could prevent instrumentalization of health equity assessments by those working for, with, or within the US State Department? What sort of ideas might you have?
I wonder if the person who asked that question is thinking of the full page ad that Pfizer took out in the New York Times that was headlined equity, right? So of course it's a risk. And what normative frame has not been instrumentalized? Human rights has been instrumentalized. Ethics has been instrumentalized. Morality, so I think the safeguard there is transparency. You're not going to have a participatory approach to defining equity that does not include the private sector, that does not include faith-based communities. You couldn't and you shouldn't. But if those discussions happen in the light of day and not behind closed doors, I think transparency can go a very long way as a safeguard against co-optation.
Thank you. And others, folks, please do put in your questions or your comments, in fact, because one of the things Jonathan asked for was people's thoughts as well. So I do want to encourage you to think about that. Another question, which is, what is the best way that you can think to sensitize large organizations in health equities so that their programs and funding can better promote more equity? Policies from leadership, trainings, workshops, programmatic level, what's the kind of mix that you see that might be most effective?
I think it's always going to depend on the organization. And you can only sensitize an organization by understanding what really matters to it. I will say that almost across the board in 2022, organizations working in this space that don't get on this train risk irrelevance. So any organization that has to raise money from donors or stay relevant in the field would be well advised to embrace an equity agenda. But I also think this comes back to the co-optation risk. And we could have the same conversation about equity, about localization, right? So the whole localization of aid agenda, funding local groups, which is very much part of this. And what's ironic is that a lot of the major Washington-based development contractors, shall we say, are embracing the localization agenda. And they're saying, funding us is localization because we have offices all over the world, right? So again, transparency. That's when other groups, the Oxfams and so on, come back and say, no, we need to have a transparent, rigorous discussion about what localization is, what equity is. But I think, yeah, I mean, I worked at the same organization for 16 years and went through so many of these processes of trying, along with many colleagues, to sensitize the organization to new ideas in health. It's completely possible. I think it comes back to partly what I said about the management of the organization and the mission of the organization being ultimately the same thing, and different organizations are going to respond to different incentives.
Okay, totally fair. So I'm going to take the prerogative because I don't see other questions listed, but please, folks, do put them in. Just from my question to you is, you named kind of some really important strategic areas, right, that needed to be done. The issue is resources are scarce, all of that. What would you prioritize? How would you think about that if you were in a decision-making mode?
I mean, as I think about that, excellent question. Fortunately, and as you could probably tell, and as you know, I mean, all of these areas that I mentioned are things that have lots of people working on them, right? So my role, our role in giving this lecture and convening dialogue around this is not to, engage in priority setting. I think it's at this point to synthesize ideas, to help lead thought and conversation about it. But in many ways, the prioritization question that you're asking comes back to the theory of change question, right? So no one's in charge here, but I would prioritize, if my priority broadly is a global health equity diplomacy, I would prioritize based on which of those is going to get us the most momentum towards that. And how do we answer that is a really good question that requires power mapping and campaign tactics and so on. But that would be my first thought. Yeah.
So a number of questions have come in, and I want to make sure that I kind of get to them. And so just a few different ones. So an important question: what type of health equity policies and programs should be avoided in the U.S., given what we've learned about failed global efforts outside the U.S.?
What types of health equity programs should be avoided? What an excellent question.
It is an excellent question.
Yeah,
okay,
I'd love to know what are the failed programs.
I think it's an excellent question.
Clearly, not every equity program is a good one.
No,
thank you.
Exactly.
Yeah.
There's applause for your advocacy for community involvement and procedural equity and program design, but there's a question as to whether there's a concern that at the community level, there may not be enough education about equity. Are there risks for expecting community level change based on initiatives that are done at the government level? And I still have one or two more just for you to know in terms of our time. So go ahead.
Yeah, I mean, on that, I would say when we talk about community involvement, we have to talk about not just a process of consultation and dialogue, but a change process and a process of capacitation, right? So equity thinking, it can slow you down. It can really slow you down. And ultimately, I mean, I don't think the person is challenging the notion that communities know their needs, but whether they can translate that understanding into recommendations that are resonant for a foreign funded program is incredibly time consuming and may require a threshold process of education in order for people to even participate. That's what's so great about the GPI that I mentioned. The co-creation process has really slowed it down. That's why most people haven't heard about it yet. But slow and steady wins the race.
Right, there you go.
Yeah.
All right. An important question from a student, right? Where basically who says, I really appreciate this nuanced take on what a future where global health equity is elevated. But as a student, I'm increasingly concerned that professors and leaders within the university underestimate the gridlock in our global system. The fact is that precarious employment, climate disasters, health crises, the proliferation of authoritarian regimes are all creating an increasingly unstable world. Global health exists in this context. Are these problems that we can actually fix? You know,
Thank
how
you
will
so much. I am humbled by the question. I would want to know from this student, and maybe we can talk about this with our student advisory council, or what would it look like for a professor not to underestimate that gridlock? You know, what would it look like? What would it sound like? What would it feel like? I hope it's okay to ask that. I think I try to get it. And I suspect one thing it could look like is just more listening, more holding of space in the classroom to acknowledge, rather than assuming that the political strategies that worked in our generation will work in yours.
Totally, I super hear you. I'm going to give you the two last questions because this is your final moment before we have to close. So I will give you our two questions, which is, first of all, what's the role of each of us in trying to bring attention to these issues? Can this in part be driven from the grassroots? How do we build better alliances? Essentially, kind of what are the roles of folks that are here on this? And then the second question is, what role do you see, if any, for the international community at large, specifically from the UN, WHO, and the like, in supporting and advancing this global health equity policy and diplomacy proposal? And I'll just let you know, lots of thank yous for this wonderful lecturer coming in as well, but I'm not reading you those out loud. So go ahead.
Yeah, I mean, in terms of your role, it's all about making a difference, and different people make a difference in different ways. I definitely want to highlight the incredible importance of local action in this. I think every time we break down this false binary between local and global and understand the work that we're doing in our communities in Los Angeles as global health work, we are really doing the work of equity. And we should think about it that way, and we should talk about it that way. So definitely like local activism and connecting those threads to global work. The role of the UN and WHO is, it's historically a normative role and a technical role, right? And they've done quite well on this. I mean, the work of the WHO Commission on the Social Determinants of Health really needs to be brought out. I think WHO should hold its ground on that, relentlessly point out how relevant that work from 2008 is to the current moment, beef up its technical capacity. I don't know how big its unit on promoting health equity impact assessment is. They should have a person in every country helping governments with those. So there's a lot that the UN can do. Yeah. And thank you all. Yeah.
Thank you all. Let me thank everybody for attending. Jonathan, again, that was amazing. And please, everyone, visit our website, follow us to learn more about our work. And please, let's all get involved and do this work together. All best to everybody. Take good care.